Thank you. And thank you very much to Stefano and the whole of the Isokinetic team for such a great event, just to echo everyone else's thoughts. Yes, my presentation is going to be looking at cartilage repair rehabilitation guidelines. Now, in 15 minutes, I'm not going to be able to cover every single guideline for every single one of the new surgical procedures and existing surgical procedures. Totally impossible. So what I'm going to be looking at is actually giving some considerations for when you do have a player coming through who has undergone cartilage repair surgery, and some thoughts as to areas that you can start to look at when working with your player in that rehabilitative period. So if we're looking at the rehabilitation, what are the rehab goals? Well, ultimately, we're looking at delivering a program that provides the best environment for that cartilage repair to produce a durable repair tissue. We've already heard the importance of that in the equation. And from a sports point of view, enables the player to return to their optimal level of function and performance in the shortest possible time. We have to be careful, though, or considerate for the fact that we know that these repair techniques, there are still issues associated with those, and there's still morbidity. So it's actually looking at returning the player with whilst minimising the risk of re-injury and future ongoing problems. So for all of the repair procedures, the rehabilitation will actually be looking at these main aims. If you have a look at the slide I've just put up, you'll see this is just a selection of the variety of rehabilitation guidelines that are out there that are produced by surgeons, cartilage repair centres, and also the companies, the corporate sponsors. From these guidelines will give you a good basis to work from, but they need to be individualised for the player, especially when you're looking at elite level. So there are a large number of guidelines out there. There's an increasing amount of knowledge synthesis in rehabilitation, and these are just some of the journals where rehabilitation has actually been covered in the last 2 or 3 years. So there is now starting to be some evidence base. There's still a lot of gaps, but there is some there. And as we've already alluded to with the other speakers, the FIFA ICRS supplement has some good papers that will give a lot more background and some of that evidence base. And I'd also like to highlight the recent last month's publication in the Journal of Orthopaedics and Sports Physical Therapy that again underlies the principles behind the rehabilitation in far more depth. All of the cartilage repair techniques are going to be going through a phase of recovery and protection from the surgery, whether that's 1 or 2 step. The transition phase, when you're looking at working with that player to restore range of movement and increase muscle strength, and then looking to add on into that strength, endurance, function, and continued neuromuscular activation, ending with a maturation period, which will be the return to full, hopefully unrestricted activity and continued participation thereafter. Now, we've heard the timescales for that will vary dependent on the type of surgical technique. So the OATS and the microfracture technique will be a shorter period compared to the cell and biological techniques at the moment. But any cartilage repair rehabilitation program will need to go through those steps and linked in with the healing process. So there are some core components of all of the rehabilitation. So initially, it's looking at addressing management of pain and infusion in the joint. There will be some element of weight-bearing restriction and weight-bearing progression. That will vary dependent on the joint that's involved, so maybe fairly limited when you're considering patellofemoral joint lesions, longer duration of restriction when you're looking at tibiofemoral. They will all include restoration of range of movement and exercises for that, the enhancement of neuromuscular aspects, strength and endurance, and although it's not usually as detailed in the guidelines, they will, if you're dealing with a sports person, you need to be looking at the effective deconditioning of the time from pre-surgery and right the way through rehabilitation, and actually looking at impaired sports function, so the sport-specific aspects of the rehabilitation. And that last bit is actually the one where most of the rehabilitation guidelines and protocols are pretty poor, and there's reasons for that I'll come on to later. Rehabilitation guidelines are just that, they're building blocks. The problem with them is that they're generic, and they are, in the main, actually focused on the general population, which may or may not be active in exercise participation. They're also not athlete-specific and not sport-specific in the main. So when we're looking at particularly a football player coming through that's had cartilage repair surgery, there is a need to individualise those programmes and to look at gearing that programme to be as sport-specific as possible, as early as possible. And I think that's where the challenge is when working with these athletes. So implementing individualised rehabilitation, yes, we need to look at the surgery, and we need to look at the surgical characteristics and the defect. We need to be looking at the biomechanics, and we need to be looking at the sport-specific aspects. And last but definitely not least, we need to be looking at the individual player characteristics. So age, what their motivations are, because they're all going to impact not only on the outcome, but also on the rehabilitation process itself. So we've heard quite a bit already this morning in terms of the variations in terms of the surgical technique. The number of defects and the size of defects is relevant because that is going to influence the rehabilitation and the speed of rehabilitation. And any other surgery that is performed at the same time, again, is going to need to be taken into account. We also have the individual factors, and linking in with some of these, yes, the type of sport, very importantly, the level of sport as well, because that will have rehabilitative consequences in areas that you perhaps might not consider so much, along the lines of access to resources, access to medical team support, those types of areas. The right-hand side of the slide, I've put some points in terms of the self-efficacy and the motivation. These are increasingly coming through as being key elements within rehabilitation after cartilage repair, and especially due to the length of the rehabilitation period. And that is interlinked as well with the social support, and that may be from friends and families for the player, but in an elite professional situation, it's actually probably as, if not more likely, to be the coach, the team, the management structure around that player, and how that support system helps to get that player back. And also the general health of the player. We're looking at cartilage repair here, but we need to be cognizant that that player may actually have additional health problems that would need to take into account. So all of these factors need to be sort of put into the mix when we're looking at the rehab. And I've put some of those, the implications of those, on this slide here, and we've already covered some of these in terms of the size and the number of the defects, the duration of the symptoms. We know that if there's a longer preoperative duration of symptoms and a lower baseline condition, then it's going to take longer to get that player back if they can go back. The patient motivation and individual goals, the second one from the bottom, I think is particularly important, especially as we start to get more arthroscopic procedures coming through, where actually the clinical symptoms for that player may decline or actually go within a fairly short space of time post-surgery. It doesn't mean to say, though, that the rehabilitation of that cartilage repair isn't continuing. I think this is where anyone working with the athletes on the rehabilitation needs to bear in mind the caveat that, yes, a highly motivated athlete, you should be able to progress faster, but in actual fact, in some instances, you may want to slow that down so that you are allowing the cartilage repair, the cartilage graft, to actually catch up almost. And I think that's a big issue in terms of education, not only for the therapists working with the athlete, but also the athlete themselves and the coaching team, so they can understand what's going on and how long these repairs take to get a mature graft, so that there's an appreciation as to why perhaps you're looking to slow an athlete down, even though they're not presenting with significant symptoms. And if there are concomitant procedures, then the general rule of thumb is that it works on the basis of the slowest rehab times. All of the rehabilitation is really built on the effect of loading, on the articular cartilage, and also, as we're finding out now, more and more on the subchondral bone. So loading is really a key factor. And we know that one of the roles of the articular cartilage is to optimize loading through joints. And we also know that at extremes, that actually can be detrimental. But we also are now aware that it's necessary to expose that cartilage, the repaired cartilage, to loading, because that will have beneficial effects. And this is where, in terms of the rehabilitation, this is getting to be more of an art at the moment than perhaps a science. Because on one hand, it's good to have moderate dynamic compression and shear stress, because that will actually stimulate the extracellular matrix. So that's what you're looking for to get that nice durable repair tissue. And we know that immobilization and static compression actually slow and inhibit that process, so we want to stay away from those in our programs. But the big issue is, and this is what I keep getting asked, well, what is this moderate? And it is not a question that we can answer at present. It's a very grey area as to how much is too much and how little is too little. But we do know that it has to be within that zone. So the way that we're working in terms of assessing whether that's moderate is by looking at particularly the top 3 clinical criteria: pain, swelling and effusion, especially after activities and particularly after there's been any progression in the rehabilitation. That needs a close monitoring and ideally looking at small step progression so that you can monitor the response of the athlete to those changes, and if appropriate, if the clinical criteria are increasing, to actually regress or hold the rehab at a plateau. Large steps in rehabilitation and not having the monitoring is going to potentially actually cause that athlete, that player, more problems. So swelling, pain, effusion after you're progressing your rehabilitation, and to do that in small steps is really the best. Mentioned about the fact that you have loading restrictions and partial weight bearing restrictions in virtually all of the rehabilitation guidelines. If you are working with elite or professional athletes, there are some ways that you can actually look to adhere to those restrictions, but also increase functional activities. And a couple of examples here in terms of using aquatic therapy. You can look at some of the underwater treadmills, so you're maintaining partial weight bearing, but you're actually able to get that athlete back to doing sort of walking, jogging, running earlier than they would be. And similarly with the positive air pressure treadmills, such as the Alta-Gravity, Alta-G treadmill. And one of the things that we found in our centre with our Alta-Gravity treadmill is actually the psychological effect it has on the player, because they're throwing away their crutches for a period of time, and they're able to get back into doing some walking, and it's just, psychologically it's very beneficial for those players. And it does allow you as the therapist to start to work on some gait retraining aspects earlier than you would do if you had the partial weight bearing on land. The other aspect I would like you to consider is how you're matching the exercises that you're selecting at the various stages of the rehabilitation to the defect location. And there's a lot of information out there about the articulations in patellofemoral, tibial-femoral joint, and it's an awareness of that and the implications that could mean. So Eckstein in 2006 actually did some very nice in vivo work looking at different activities and where the pressure was on the cartilage. And if you're starting to think three-dimensionally with your player, and you know where that defect location is, and that isn't just that it's on the femoral condyle, but exactly where that is, or whether it's proximal or distal on the patella, you can actually start to gauge or gear the exercise selection around that location. And for instance here, if you have somebody that has a distal patella cartilage defect, that is something that you may think, well, they're more likely to have some symptoms when they're walking, but perhaps actually when they're in deeper degrees of flexion, that might be okay. So you can start to actually be a bit more selective and individualized in your selection of exercises. None of the rehabilitation protocols will actually go into that level of detail. They'll specify whether it's patella, trochlear, medial femoral condyle, lateral femoral condyle, tibia, but not into the specific area of the defect. And one of the last points I want to actually look at is the fact that return to play does not equal the rehabilitation has been completed. And again, major education communication here, because the assumption with a lot of players and coaches is that the player is back, they're playing matches, the rehabilitation is completed. This is definitely not the case when we're talking about cartilage repair and subsequent years afterwards. And I've just come back from Western Australia and working with J.E. Burt and his team at Perth Orthopaedic Institute. And this was the paper that's just come out in Clinical Biomechanics, where they're looking at isokinetic knee extensor strength 5 years after Macy, in which they've had, these were 60 patients. They weren't athletes, but they were active sports exercisers. And 5 years after their Macy, they had extensor deficits in strength. So this wasn't an elite sports population. It may not be the case, but it does indicate that even if you have a very good supervised first 3 to 6 months of rehabilitation, it doesn't necessarily restore all of these areas. So up to 5 years, still not back extensor strength, so something that we'd want to address. So the returning player, the rehabilitation hasn't been completed. There's quite a bit of evidence that shows that it takes up to 3 years to get full maturation for some of the articular cartilage. So that is going to be the minimum period for the rehabilitation. The big question is looking at whether or not that athlete can accept the load of the sport. And it may be that there's quite a bit of coach and player education needed and multidisciplinary management for that player who's coming back into the sport to actually make sure that they can accept that load and continue to accept that load without any progression onto more degenerative changes. So some considerations: first season back, perhaps looking at increasing recovery time, substituting some of the pitch sessions, perhaps possibly with some less impact pool sessions, decrease that number, and close and continued monitoring. So continuing to consider, is that player expressing any clinical symptoms? Is that an indication that actually there are further changes carrying on? So the returning player, rehabilitation isn't stopped. So in terms of key points when you're looking at implementing cartilage repair rehabilitation, first, get the information, all the information, the surgical detail, the precise location, the surgical report. Get the rehabilitation guidelines that either the centre or the surgeon are supplying. With those, you've got the building blocks for actually then knowing what you're doing, and you can then use your expertise in therapy, in rehabilitation, to actually individualise that. The biomechanics, extremely important, and differentiating between the different joint surfaces, particularly so in exercise selection. And we need to be thinking about respecting those biological timescales all the way through. Doesn't mean they're necessarily obstacles, but we need to respect them, and there are ways to work around them, but they will not change. So that's going to need knowledge and application of functional rehabilitation and principles of training, and making sport specific. So even at the early stages, if you're starting to look at some pull work, just for a footballer, if you're throwing the ball to them and they're heading it back to you, little things will actually make a difference, and that should be as soon as possible and continued right the way through. So I've already mentioned about working around the restrictions and supporting the player. It is a long process. Some of these injuries can and are career-ending, so the return to sport isn't the end of the story, and these players will need monitoring for future problems later on, and from what we've heard this weekend, probably after they've retired as well. So hopefully some considerations for you on how to implement the rehab. Thank you.